Thank you for joining us today. Today we are talking about constipation and diarrhea. This is one of our sessions as part of the evidence-based palliative symptom assessment and management series. And before we begin, we would like to go ahead and do a brief land acknowledgement. We would like to acknowledge that the land in which we are gathered on today is the traditional land of the Anishinaabe Nation. Specifically, Chippewa Tri-Council comprised of the Chippewas of Beausoleil, Rama, and Georgina Island First Nations, and most recently, the Mississaugas of the Credit River First Nations. Ontario is covered by 46 treaties and other agreements and is home to many Indigenous nations from across Turtle Island, including the Inuit and Métis. These treaties and other agreements, including the One Dish, One Spoon, Wampum Belt Covenant, are agreements to peaceably share and care for the land and its resources. Other Indigenous nations, Europeans, and newcomers were invited into this covenant in the spirit of respect, peace, and friendship. Most of us have come here as settlers, immigrants, or newcomers in this generation or generations past. We are all treaty people. Every day, we are mindful of broken covenants, and we strive to make this right. We commit to collaborating based on foundational assumptions that Indigenous peoples have the power and strength and competency to develop culturally specific strategies for their communities. We are dedicated to honoring Indigenous self-determination, history, and culture, and are committed to moving forward in the spirit of reconciliation and respect with First Nations, Métis, and Inuit people. Thank you for joining us today. And we would like to acknowledge the financial support we have received from Health Canada. The Palliative Care Echo Project is supported by a financial contribution from Health Canada. Thank you. And today, my name is Amanda Tavelda. For those of you who haven't joined us in the past, I am Communications, Fundraising, and Public Relations Specialist with Hospice Aurelia. And today I will be your host and moderator. So I will be keeping an eye on the chat box and helping out when we have the Q&A section. Our presenters today are Inga and Kathy. Both are hospice palliative care nurse consultants with the North Simcoe Muskoka Hospice Palliative Care Network. Ladies, the floor is all yours.
Thank you, Amanda. Kathy, yours.
Okay, so our learning objectives today are to identify tools used to assess for constipation and diarrhea, assess and manage constipation and diarrhea, and identify the steps in the case of constipation and diarrhea. Just hang on a minute. Okay. So the definition of constipation is here on the screen. 2 seconds. I just need to move. I'm so sorry.
We're in the way, are we?
Yeah, we're all in the way. So the symptom of unsatisfactory defecation is characterized by infrequent stool, difficult passage of stool, or both. Difficult passage can mean straining at stool, incomplete evacuation of stool from the rectum, or passing hard or lumpy stools, prolonged time to pass the stool, or the need for manual maneuvers to pass stool. Infrequent defecation is one of the most common problems in palliative care. Patients in palliative care are often predisposed to constipation related to the medications that they're taking and the fact that they are becoming less mobile, especially in later phases of their illness. This is a symptom that should be routinely assessed for. It's a subjective symptom, with clients often complaining that they are having incomplete passage of hard, dry stool. Obstipation is a partial or a complete bowel obstruction which results from severe constipation. Clients should be having at least 3 bowel movements per week, or no more than 3 normal bowel movements per day is considered normal average frequency. Clients may also have associated symptoms of headaches, gastric reflux, bloating because of gas. They may become anorexic and feel nausea and cramping. In the palliative setting, a patient should not go for more than 3 to 4 days without a bowel movement. The definition of diarrhea is feces are discharged from the bowels frequently and in liquid form. So loose watery stools that occur 3 or more times in a 24-hour period is considered to be diarrhea. Have associated abdominal cramping, bloating, nausea. They'll have urgency, and they may or may not have blood or mucus in their stool. It's usually short-lived and lasting only about 2 to 3 days. So the function of the colon or the large bowel or the large intestine, the colon or large intestine is part of the digestive tract. It begins with the mouth and it ends at the anus. The large intestine is approximately 5 feet long and is composed of 4 parts: the ascending colon, the transverse colon, descending colon, and the sigmoid colon. In this picture here, you can kind of see the dark pink is the large colon. So you would see the ascending colon, if you're looking at it dead on, it's the left side of the left side, but it's really on your right side. You have the ascending colon, transverse colon, and descending colon. And unfortunately, in this picture, the small bowel is sort of in blocking the sigmoid colon that's under there. So the colon, it plays an essential role in processing indigestible food materials for most of the nutrients. And most of the nutrients, at least 90% of water and nutrients have already been absorbed by the small bowel. The ascending and transverse colon will absorb the remaining water and nutrients from the indigestible food materials. Bacteria that is in the large gut, it will process through a process of fermentation, further break down the indigestible food material and in result of formed feces. So the descending colon will store the formed feces. Sigmoid colon will contract to help move the feces along into the rectum, and the rectum holds the feces awaiting elimination by defecation. So some of the causes of constipation are drugs, such as opioids, and drugs with anticholinergic actions, such as antispasmodics, phenothiazines, some benzodiazepines, statins, and antihistamines. 5-HT3 antagonists, such as ondansetron, iron supplements, and chronic laxative use. Some dietary issues would be having a low fiber diet, decreased food intake, and decreased fluid intake, which we see in our palliative patients. Some physical barriers would be, again, their decreased mobility in the palliative patient and overall generalized weakness, and sometimes they are ignoring the urge to defecate. Environmental barriers would be having a lack of privacy, such as having to use a bedpan or commode chair, having caregiver burnout in the home where the caregiver is too fatigued to continuously attempt to toilet the patient. And then again, the physical layout of the home, the toilet and the bed may not be as close together, and the patient may be too weak or too tired and less mobile to get there, and may, just put off going to the bathroom. Some of the disease effects may be bowel obstruction related to pelvic tumors or masses. There are other endocrine and metabolic issues such as hypercalcemia, hypokalemia, dehydration, hypothyroidism. Neuromuscular diseases such as Parkinson's, multiple sclerosis, ALS can cause decreased abdominal muscle tone, therefore making it more difficult to have a bowel movement. Some treatments, such as chemotherapy, can be constipating, and advanced age of a patient may also be reason to be constipated. Having concurrent diseases like irritable bowel syndrome, patients who have COPD and CHF are often too fatigued. They find it really exhausting to try and go to the bathroom and to sit to have a bowel movement. It's very stressful for them. And also having painful anorectal conditions like a hemorrhoid. So some causative factors for diarrhea, again, are drugs. So laxatives, antacids that may have a magnesium base, antibiotics, again, chemotherapy and immunotherapy can cause diarrhea. Some disease effects may be infections like C. difficile. Patients may have a primary large bowel cancer that will create overflow diarrhea because of a block. Pancreatic insufficiency. Patients receiving treatments like radiation may end up with a radiation enteritis. Some surgical interventions like gastrectomy and small bowel resection, they would end up with maybe short tract syndrome, which would, it causes increased transit time through the bowel and therefore would be very liquidy stool. And also having fecal impaction and therefore overflow diarrhea with seepage of watery stool around the impacted stool. Also, again, having concurrent disease such as irritable bowel syndrome, which, as we know, fluctuates between constipation and diarrhea sometimes, and having inflammatory bowel disease like colitis. And that's on to you, Inga.
Thanks, Kathy. So the next part, we're going to look at assessment and tools that we've got available to us. So here are some of the assessment tools, the ESAS, the PPS, the Bristol tool, the acronym symptom assessment, the OPQRS-UV tool, abdominal assessment, rectal exam, and the X-ray, like the flat plate of the abdomen. We're going to go through all of those a little bit more detail. So the ESAS stands for Edmonton Symptom Assessment System, and this is what it looks like. It's a tool that was developed to help with 10 different symptoms. It used to be 9 only, but they've added the bowels on there as number 10 that are common in palliative care patients. So it's about pain, tiredness, drowsiness, nausea, appetite, shortness of breath, depression, anxiety, well-being, and bowel function. And then they've got a 10th or 11th one that might be patient specific that we might want to use for something else. It's intended to capture what symptoms you are having and how severe. And it's intended to do that in the here and now. So not to say, okay, my pain can be, or my nausea can be, but what is it right now? All those symptoms are very subjective. So we would really like the patient to be able to give us the numbers for that. However, of course, in a lot of instances, we have patients that are cognitively not as well, and we might need some help from the caregivers to see what their understanding is of the symptoms. This is not a one-time use. We need to do this whenever we go and do an assessment with a patient. We actually sometimes ask a patient to do it daily at a certain time of the day or weekly, just depending on what is happening, just to see if perhaps we put a treatment into place to see if that treatment is going to make any changes in those numbers. The ESAS is only one part of a holistic clinical assessment and should not be thought of as a complete symptom assessment. Any symptom that is higher than a 5 should be further assessed, and we normally use the symptom assessment acronym, the OPQRS-UV assessment tool, and we'll get into that in a little bit, to dig a little bit deeper with those symptoms. The severity of each symptom is rated on a scale to 0 to 10, where 0 means that symptom is not present, and 10 it's at its worst. And again, it's for how they are feeling at that point in time. So the next one we're going to look at is the PPS, the Palliative Performance Scale, and this is what it looks like. It's a little bit blurry. I hope you guys can see it. So the PPS scores are determined by reading horizontally at each level to find the best fit for the patient, which is then assigned to the PPS score, which is your first column. Begin at the left column and read downwards until you find the appropriate number that goes with that, the ambulation. If you're looking at the ambulation, that's the first stuff that we're going to look at with the patient, and this PPS score is quite nice to do because it only takes like 2 or 3 minutes to do a PPS score. So you're starting at the ambulation, you're going down to where the level of the patient is, like it might be a 70, it might be that their ambulation is reduced, or it might be that they're mainly in bed and they're 40%. Once you're there, you're then going to go to the next column, the activity and evidence of disease, and fit up the one that fits with the one before it. So if you're looking at the mainly let's look at reduced. There's two that are saying that they are reduced at 70 and 60% of a PPS. So when we have 60 or 70, we still need to narrow that down and say, okay, so which one actually does belong to this patient? Then you're going to go to the next one and match up the best wording that is associated with the one before it. And if you're looking at 70 and the activity of evidence of disease, 70, it's unable to do normal job or work, there's significant disease, but 60%, it says unable to hobby, do housework, significant disease. So there's a difference. 70, they're still able to do some more than what they are doing at 60%. So then you can tailor it down a little bit more. You're not going back up from there. You're always going across and down. So if you've got one of those two and you're not totally sure which one it would be, then you're going to go to your self-care, match it up as good as you can, then the intake, then the conscious level. So you're repeating these steps until all 5 columns are covered before assigning an actual PPS for that patient. So the leftward columns are heavier weighing than the ones on the right. The first column, you're seeing the PPS score, you see it goes down by increments of 10%, and we only use the 10% increments. Nobody is a 52 or a 37 or a 75. It only goes down by 10% increments. Sometimes it's easy to place a person, especially if you're using this tool a lot. It's quite easy to place a person in the percentage that is going to fit with them. PPS may be used, I should also say, from the PPS 100 to 80%, where the ambulation is still full, we normally say that a person is still very stable in their disease processes, like they still are functioning quite well. From 70 to 40% is where the person would be considered to be transitional in their disease. A person is going to start needing to get some support from other people to sustain their daily living. From 30 to 10 is where a person is totally bedbound. And that is the part where we say the person is at end of life. Still, that can be lengthier. They're not particularly right in the dying process, like actively dying, but they are in their end of life process. So why would we use a PPS? PPS is a great tool, communication tool between team members. It's very easy to do. Like I said, it takes about 2 or 3 minutes. And to have those numbers and relay those to a team member, it just gives you a full picture of what is happening with a person. It also might have some value in criteria for workload assessment. And we also see that it has a little bit of a prognostic value. So if you see a person's PPS going down with 10% over a month's time, then we probably still have quite a bit of time left. If it goes down by 10% in weeks, then we probably have weeks left to the end of life for this person. And the same if it goes faster than that. I hope that was a little bit clear. I love this tool. It's one of my favorite ones to use in the palliative realm. So the next one we're going to look at is the Bristol tool chart, and this is what it looks like. So the Bristol tool chart is a tool used to assess human stool, so the poop, based on the shape and the form and how loose it is. So it goes from type 1 to type 7, where type 1 is the hardest stool, so a person is very constipated. Type 7 is where a person would have diarrhea. So we're kind of aiming for a type 3 or a type 4 Bristol stool chart. And I'm very happy to say that in the last little while, I have seen people using this in long-term care as well as in hospitals, which is quite nice to see. So the next one we're looking at is the acronym symptom assessment tool that I alluded to a little bit earlier. So the OPQR-STUV. It's a tool to aid in a systematic assessment approach to whatever hospice palliative care symptom you are reviewing. Now, this is what it looks like, and this chart happened to take the appetite in consideration. So the symptom assessment acronym tool assists healthcare providers in completing a comprehensive comprehensive symptom assessment when a patient identifies the symptom occurring or experiences to be distressing. Symptoms normally over 4 or greater on that 0 to 10 scale. The acronym tool has been developed to help care providers collect relevant information systematically when completing a symptom assessment. Physical symptoms may include dyspnea, constipation, nausea, fatigue, and etc. So any of the ones that we've mentioned before can be included in that. So the O is for onset. The P is for provoking or palliating. Q for quality, R for related symptoms, S for severity, T for treatment, U for understanding and impact on you, and you can read behind what it all means. The V for value, and in this chart there's an extra one, there's the W for weight, because we're talking about appetite. And even with constipation, you might even put that question in there. Has your weight changed? Is it gone up or down? Next one we're going to look at is the abdominal assessment. So auscultation of the abdomen as it relates to the GI system is performed to assess for intestinal function, specifically bowel sounds. Bowel sounds are produced by the movement of fluids, gas, and contents through the intestines. So the abdominal assessment contains examining of the abdomen for abdominal distension. So you're going to look at it and you're going to feel it. You're going to listen to it for figuring out if there's increased or decreased bowel sounds. And you're going to palpate for distended bladder or any other abdominal masses that might be present. Next assessment is the rectal exam, which is a little bit of an invasive procedure and should only be performed after completing a full assessment of constipation. Another thing, and you for sure have to ask for permission of your patient before you do anything like that. It probably depends where the person is in their trajectory. I don't see it used a lot of times, but it might be a valuable tool to just figure out if there is an impaction right in the rectum, or if it's something that is sitting higher up and different treatment needs to be thought of. So the last one we're going to talk about here is the X-ray, the flat plate abdomen. The X-ray is a widely available, inexpensive, and easily obtained imaging test to assess for constipation. And I think sometimes it's underutilized in the palliative realm. Radiology is an important tool in the diagnosis and treatment of patients with constipation. Imaging provides both vital anatomic and functional information that may facilitate arriving at an accurate diagnosis, assessing for serious complications, and delivering the appropriate therapy in a timely fashion. Again, we have to think about goals of care for the patient. Is this something that we can utilize to figure out what is going on with your patient? Kathy, I'm giving it over to you.
So some of the non-pharmacological treatments for constipation would be regular exercise like swimming and walking, increase the content of fiber in your food, like choosing high fiber cereals and legumes. Try to desist from waiting or holding in the urge to defecate. Avoid processed or fast foods like white breads, donuts, and pastries. Try to drink more fluids, especially water, and eat more fruits and vegetables as they help relieve constipation. And for those vegetables and fruits that have edible skins, it's best to leave them on and not peel them off, as they are very rich in fiber and good for you. Also, just to add, many patients, some of the more elderly patients, but many patients have been using prunes or prune juice in the past to help with their constipation instead of using laxatives if they can. So some pharmacological treatments for constipation would be senosides, which is an oral colonic stimulant, which reduces water and electrolyte absorption in the colon. Lactulose is an oral osmotic. It softens the stool and works as a stimulant to move the stool. Polyethylene glycol is an oral colonic osmotic. It often known as PEG. It works pretty much the same way as lactulose, but it might be more palatable lactulose polyethylene glycol can be used. It's odorless, tasteless. You can put it in your coffee, your orange juice, your water, and drink it down in the mornings if you need it. Sometimes people find that lactulose is, although effective, they often have difficulty taking it given that it's quite sweet and syrupy. So suppositories can also be used. Bisacodyl, which is Dulcolax. It stimulates peristalsis and evacuates stool from the rectum. And glycerin suppositories also, they are osmotic stimulants, which often softens the stool in the rectum. They should be avoided in patients who may be at high risk of bleeding or who are neutropenic. Enemas, such as phosphate enemas, which stimulate peristalsis and have an osmotic effect and will evacuate stool from the rectum and the sigmoid colon. So tap water enemas or large volume enemas will evacuate stool from the descending colon, and oil retention enemas work to soften hard stool. These two should also be avoided in people who are at high risk of bleeding and for those who are neutropenic. Methyl naltrexone, which is used for opioid-induced constipation. It is a mu-opioid receptor antagonist. It doesn't interfere with the pain effects of your opioid, but it it will, and it doesn't cause any kind of withdrawal effects, but it does block the effects of what opioids do in the gut. This is a drug that's not covered by ODB. It's usually given subcutaneously. It's fairly expensive, so it's sort of something that might be thought of by a physician if the patient understands that it's probably an out-of-pocket pay, or as long as they may have some private insurance to cover it. So some non-pharmacological treatments for diarrhea. You may want to increase foods that are high in soluble fiber. You might think about instituting the brat diet, which is bananas, rice, applesauce, toast, which will help promote bulkier stools. Try to increase fluids such as water, broths. You can also add things like Jello or clear tea. You could also think about an X-ray. Again, Inga talked about doing a flat plate of the abdomen, just to make sure that this patient isn't constipated and having overflow diarrhea. You might consider doing stool cultures if you are suspecting that the patient has a pseudomembranous infection like C. difficile. You may want to readjust a patient's laxatives. If a patient is using laxatives on a daily basis along with their opioids, sometimes they end up getting too loose, their stools, and it's sort of a delicate dance. Patients have to sort of back off, but they shouldn't really stop taking their laxatives. They could maybe stop for a couple of days, or maybe try every other day or every 2 days and see where their stools are at, just to sort of pull back and see their stools become more formed, but never stop taking your laxatives. You might want to review a client's medication. A good time to do maybe a med reconciliation to take a look at the medications that the patient might be receiving. They may be on something that is causing the diarrhea. That's it. And so pharmacological treatments for diarrhea. So loperamide, which is Imodium. It is an antidiarrheal agent. It works by decreasing the flow of fluids and electrolytes into the bowel, and it also slows down peristalsis. So you're decreasing the number of bowel movements. Lomotil or diphenoxylate, which is also Lomotil. It's an antidiarrheal agent. It is usually given by prescription, as it is a controlled substance. It works by binding to certain proteins in the gut. So mu-opioid receptors to control and decrease peristalsis. Opioids might be considered if the patient is not already using it as a pain reliever. Metronidazole is an antifungal that can be used to treat bowel infections such as C. difficile. Octreotide is a subcutaneous statin. It can be dosed BID or TID. It might be considered for severe refractory diarrhea. I have not seen this used, but I guess it can be used, and it's been documented as used as an antidiarrheal. Parenteral rehydration may be required for cases of, again, severe refractory diarrhea. You might want to remember to inspect a patient's perianal area, or talk to them about if they're having any kind of inflammation or excoriation in that area, and that, you know, you might suggest that they try zinc-based barrier creams, or even corticosteroid creams can also be considered for the same. If the patient is constipated or you know, they're having overflow diarrhea, and it's found that they are constipated, and this is the reason that they are going to need oral laxatives, and maybe even enemas or suppositories need to be instituted so that their bowels will move and the diarrhea will subside. And often, sometimes they may have to resort to disimpaction. I've not seen this done for a very long time. It's something that I don't think they're really doing as much of anymore, given that all the laxatives that we do have, they're quite useful. But if this procedure is something that needs to be done, then you might want to think of sedating your patient. And I just want to say that basically for all of these investigations and treatments, things like, you know, IVs, IV fluids, antibiotics, or discontinuing medications, that we need to always be consistent and respectful of the patient's goals of care.
For sure, thank you. Thank you. So for the last part of this talk, we're gonna have a look at the case study, and I'm gonna ask you guys to put your thinking hats on for the end of it. So when we're looking at the next case study, we're going to talk about Peter and Everett. Peter is a nurse practitioner. He is a community-based nurse practitioner, a member of the community palliative care team. Everett is the patient. So Peter is reviewing the patient's history outside the house in the car before visiting the patient. I'm going to have to move us too, because otherwise I can't see. There we go. So Everett is a 70-year-old retired engineer that the palliative care home care team has been looking after at home for the last 2 months. Everett was diagnosed with inoperable prostate cancer 3 years ago and has been treated with ablative hormone therapy and finished 27 radiation therapies at that time. 6 months ago, Everett started to have pain in his hips. His oncology ordered a CT scan and found that he had mets in his liver, pelvis, and lumbar spine. Everett and his wife June had a meeting with the team at the cancer center and decided not to go ahead with any further cancer treatment. Our team has been involved since that time, so this is the community palliative care team. June called Peter and asked him to make a home visit. Everett has been having more pain this week and has been spending most of his time on the couch. He cannot get around without assistance and is very fatigued. Everett's past medical history includes hypertension and reflux. He is taking prednisone 5 milligrams PO, BID, and Lupron Depot 22.5 milligrams IM every 3 months. Hypochlorothiazide 25 milligrams daily and pantoprazole 40 milligrams daily. For pain, he has just gone on to 100 milligrams of morphine slow released every 12 hours, and he has not needed any additional medication for breakthrough pain so far. So the assessment takes place in the home, and patient is seen reclining on the couch on the first floor living room. Wife June and daughter Kelly are present. Everett is awake but drowsy. June thinks that Everett has been more nauseous and not eating much. It's been happening for about the last week. He has been using ondansetron for the nausea. He hasn't had a fall, but he is unsteady on his feet, especially soon after he gets up. Everett states he tried some acetaminophen from the drugstore a few days ago, but it really didn't work. Peter finds out Everett has been a bit more sleepy in the last few days, with a bit of a queasy stomach after the morphine was increased to the 100 milligrams BID. His last bowel movement was 4 days ago. So I'm going to ask you guys to use the chat function, and I hope Amanda's here to help us out on that. So what further assessments should Peter perform?
So we have an abdominal assessment, comprehensive pain assessment.
Yep, perfect. Anything else?
Nothing as of yet. Oh, hydration.
Hydration. Is that hydration, are you thinking IV or sub-Q, or are you thinking hydration in oral form?
Assess for hydration. It's been
okay. All right, perfect.
Yeah. Also food intake.
Food intake, yeah. So do a thorough oral intake assessment. So think back about a little bit further earlier on in the talk, all the tools that are available to us. We can use the ESAS, right? We can dig a little bit deeper and see if there's anything else that is bothering him. We can do the PPS score, the Palliative Performance Scale, to see if there's any changes in his PPS. We can use that Bristol stool chart to see what actually his last stools looked like, because it's been 4 days ago. If need be, you, I guess, could do a rectal exam. I'm not sure if that's already warranted at this point, but it might be an assessment that you might be keeping in the back of your mind. And the X-ray, if need be, we can always have a look at as well. Great, guys, thanks. So let's have a look at the rest of the study. So Peter continues after consent with an abdominal assessment and applies the tools to assess the PPS and the Bristol stool chart. The abdominal assessment finds that the client's abdomen is not distended, it's not tender, with hypoactive bowel sounds in all 4 quadrants. Peter decides to defer doing a rectal exam at this time. His finding on the ESAS are that the bowels are 4 out of 10. So he's on day 4. There's no nausea right now. Pain is 2 out of 10. Appetite 6. Anxiety, there's none. Depression, there's none. Drowsiness, there's none. Tiredness is 4 out of 10. And well-being is 2 out of 10. Shortness of breath, there's none. So if you're thinking about the drowsiness, it says here 0 out of 10 because this is a subjective measurement. This is the information that we're getting from Everett, even though it said we found him a little bit drowsier, what Peter thought. So the PPS now has gone to 40% and that has been a reduction from 60% from 2 weeks ago. So that's a fair big reduction. We looked at the Bristol stool chart, and the last stool that Everett had was type 2, lumpy and sausage-like, so he's lightly constipated. So Peter finds that Everett's pain scores are showing decreased quality of life. So the pain score he's done a little bit more digging about, because Everett says pain score on the ESAS at the moment is 2 out of 10 at rest. But when he moves, it goes up to 7 out of 10. He has not been using his evening Senecot for about a week and tells Peter that he does not want to go to hospital for an X-ray. So it's given us some more information here. Peter adds a bowel regime to address Everett's constipation and provides an order for PRN anti-nauseant like metoclopramide. Everett and his family will need to have some education about bowel routines and the importance of this as he is using opioids. So we always have to consider, again, goals of care, right? That's always one of the first things once we've done our assessments and go on to the next phase. What are the goals of care for this patient and are they changing? So if we're thinking about the information that we've gotten, what do Everett and June need to know? So again, use your chat function and let us know what you think that we should tell them. What do we need to tell Everett and June? So I think the education piece regarding bowels and treatments is always one of our main things. I think it's very important for us healthcare providers to give all the education that we can to support our clients and patients. So think about Everett is on. Yeah, go ahead.
Sorry. Nancy says modify diet, increase fruits, veggies, fluids. Quinn says review goals of care, disease progression and trajectory, and palliative care. And exactly. Nancy also says increase activity.
Perfect, perfect. Wonderful, guys. Another thing is, think about Everett is on an opioid. What do we normally need to make sure that a person knows when they're on an opioid?
Kathleen says keep record of bowel as well. I think that was previous to your question. And Nancy says Senecot. Kathleen says constipating, make sure you're drinking fluids.
Exactly, exactly. So we normally, if you're a healthcare provider going into a person's home and you see a person is on an opioid, next thing you're going to ask is, what is your bowel routine like? What have you been given for information and medication to combat constipation might it occur? And most of people on an opioid will get some constipation. If a person becomes constipation once started on an opioid, they will be on a bowel routine for the duration as long as they are on an opioid. So we have to have a look at the laxative and have to do the education with the person. Like it says here, Everett has not taken his Senecot for over a week. And that's probably because he didn't realize the importance of the Senecot with being on an opioid. So that might be one of the reasons why he got into trouble. To increase fiber, fluids intake if he can, and to increase mobility if he can, would be all great suggestions. I think we have to get him through this bout of constipation first before we probably can think of him getting a little bit more mobile and eating a little bit better. So if you're thinking about getting him through this bout of the constipation, what could we add for a bowel routine for Everett?
Quinn says PG.
PG meaning?
He means polyethylene glycol, Inga.
Okay, thank you. Yep, that's a good option. Yep. I wouldn't do that one on its own though. I probably, because he hasn't been taking the Senecot, remember, I would put him back on it and then perhaps put the Restoralax or the PEG alongside with it.
Kathleen recommends lactulose.
Lactulose, and like Kathy already said, sometimes people are leery about the lactulose because it's like a syrupy, very sweet medication, and some people really like it. The Restoralax or the PEG is a little bit easier to stomach because you can put it in anything. You don't even know that you're taking it. It's tasteless, odorless, but both good options.
Sue has a question. She would like to know, should we be asking him why he stopped taking the Senecide?
For sure. There might be a reason for it. And it might be just that he needs the education to go with the Senecot and the opioids that he might not have gotten. I find a lot of times when I see a person and they are on an opioid, they might have gotten the information, but they get so much information at the time of starting on an opioid that they might have forgotten or not realize the importance of the information that they received at that point.
And Christina says Senecot 1 to 2 tablets at bedtime and also the lactulose in the morning.
Yep, both good suggestions. And I think if you would start with a Senecot 1 at night and it doesn't do anything, you can do as what they normally do with the chemo protocol. Take 1 at night, 1 in the morning if you haven't gone by morning. You can increase that to 2 at night. In the evening again, and then 2 in the morning if you haven't gone. But again, together with one of the the other preparations. One side note I want to give you though is the Dulcosate sodium. You probably all know the little red capsules, or not capsules, what are they called? The clear, well, I guess it's a capsule. The clear Dulcosate sodiums. Don't use those. There's been lots of research done, and they don't seem to have any real use in giving the bowels a little bit of an easier time. So you will see probably less and less of that being ordered for your people. Increase your liquid intake if that is possible.
I think we had a question here, Inga. I'm just trying to find, I think it was Margaret. Margaret, I'm not sure if you wanted to take yourself off mute.
Yes, maybe you want to get his spouse to start a chart for his bowel habit, you know, and also because he's taking a lot of medication, he's drowsy, so he's forgetting to take his medication. So probably his wife probably have a little more
of a visual. Yeah, I think that's an excellent idea. I think that's so helpful. If you go into a home and a person has a record of when they do what, when they take their opioid, when they are needing it, when they're taking their bowel routine medications, and what is happening with that. I think that's a great suggestion. Thank you.
Thank you.
And I think with all those suggestions, we got Everett back into shape, and he has gotten through his bout of constipation and well on his way to do the rest of his probably end of life as he would go with. Thank you, guys.
Now I have to share, Inga, before we get into the Q&A. Sherry has just said she has a picture of or she has a mug with the Bristol stool chart on it.
Oh, lovely, lovely, lovely. Lovely. I see it. I just in the last little while, I've seen it used several times, and I'm really happy with it. It's just such a visual thing. Like, not everybody is very good verbally to describe stuff, but that is just a very visual tool to use. Thank you. Any questions, anybody? We've come about at our end of our talk. I'll put up some of the references that we've used. I think there's probably a couple of extra ones that we didn't put on, but if you've got any questions coming to you after the session is done, you can always go to our website, NSMHPCN.ca, and find us there and give us an email or a telephone call, voicemail.
And if
we'll
you
get back to you.
If you could bring up the next slide, Inga, there is the QR code for
perfect. Forgot about that. That's
survey. So before everyone jumps off, if you could take a quick scan of that with your smartphones, let us know what you thought of today's presentation, and that'll help us to better shape our upcoming presentations. But so far, there's no questions, just a whole bunch of thank yous in the chat.
Thank you, guys.
Thank you.
I want to make a joke about being, people being constipated with their questions, but it's not formulating in my brain very well. I'm just kidding. That was a great presentation. Thank you so very much, Inga and Kathy. It was lovely. Oh, Margaret, you have your hand up.
Yeah, has her hand. Oh, you're on mute, Margaret.
You're on mute.
Hello.
There we go.
Hello.
There we go.
I thought it was excellent. Thank you very much.
Thank you for being here.
Yes. Bye-bye.
It's our pleasure.
Bye-bye.
Bye.
Bye-bye.
Oh, we do have a question here. We have what about Constella? I have seen the prescribed by a family physician.
To be honest, I don't know about Constella. Have you heard of it, Kathy?
Nope, have not.
Christina, can you unmute for a second?
Yeah, do you want to tell us about it?
I just saw it only one time prescribed by a family doctor. And so for a man who'd been not with opiate-induced constipation, but he had long-standing constipation. And so I'm not familiar with it really. I mean, from the experience, this man, he didn't have a bowel obstruction, but he hadn't had a bowel movement in many days. And so I don't know how effective it is, but has anyone seen it being prescribed more often?
I have not yet. I will do some research on it because, of course, we need to know if there's something new on the horizon out there. So thank you very much for bringing it up.
It's a drug that's been started used with irritable bowel syndrome with constipation.
Yeah.
So it's something the
accelerates-
patient would be taking probably for the rest of their lives to sort of moderate that irritable bowel syndrome with the diarrhea plus constipation, and they probably have overflow diarrhea. So,
Okay.
Okay, so it's used for irritable bowel syndrome, not so much for constipation.
yes,
Okay,
that's my understanding of it.
Is that what this gentleman had?
well, he had constipation. Yes, he'd been struggling with that for many years, but he was, I was seeing him for palliative care. So, I mean, really, I don't know how effective that was, but yeah, he did have that. So his family doctor prescribed that. So it was, yeah, it was interesting. He wasn't taking it as regularly as he should have probably. He's supposed to be taken every day.
Yeah, that's a lot of time, especially if people are at home. It's I used to do home care, visiting nursing, and when you left the home, people did what people wanted to do, right?
That's
Education
exactly
part,
it.
that education part is so important for them to realize and understand why we are asking certain things and advising certain things. Yeah.
And I find too with the bowel routine, we have to almost write it down for them because I find it is pretty. I mean, we'll use Senecot, lactulose, and then after so many days, suppositories, fleet enema. And when they receive all these medications, it gets very overwhelming. So I find it helps to, just to say on day this day, do this, day this day, do this, day this day. And that seems to really make it easier.
I think the long-term care facilities with their protocols have that quite good down path.
They do. Yes, they really do. Mhm.
And Linda would like to know if you could please review how you might use the Cancer Care Ontario algorithm for constipation and diarrhea.
I think that's something that people can go and look at on their own. The CCO, Cancer Care Ontario, has a really beautiful algorithm on constipation and diarrhea. Very well laid out, very easy to follow, step by step, what to do in what scenario. So just look up CCO and then look up the algorithm for constipation or diarrhea.
And we also have access to that in our virtual
Toolkit.
resource
Yeah.
binder. Mm-hmm.
Yeah.
I think just reminding ourselves that those medications sometimes can create a vasovagal response if somebody is very constipated. And so just keeping that in mind, that we need to be careful how long they've been constipated and how much opioid they've been using could be a very scary situation for someone to become unresponsive while having a bowel movement, right?
Exactly.
So just that health teaching and prep and all that sort of thing that might occur.
Yeah, bowel function, it has to work. Like, it's one of those things we can't do without. So it's just very important, even though we might not talk about it as often as we should. It's just a very important part of our functioning body, for sure.
Mhm.
And I think, and I know this is probably not fully related, but I would like to share a comment. I think it starts at a young age too, right? Like normalizing the discussion. We're normalizing death and dying, but we also need to normalize bodily functions with our children. I know it can become a very awkward conversation, like, oh, have you pooped today? And the kids are like, oh, don't talk to me about that, Mom.
Make it normal. Make it normal to look back when you have had a bowel movement to see what has happened, what it looks like, what it smells like, right? That's just, But I think us as nurses, we are inclined to very easily do that. That's just part of who we are. But yeah, to normalize that would be very nice.
Yes, for sure. Totally agree.
Margaret, you still had a comment?
Yes, I think when we talk as nurses, sometimes we use terminology that's nursey, if you know what I mean.
Mhm.
I think we have to come downstairs a little bit with our terminology with certain people.
Definitely.
Yes, Although I think sometimes if you use some terminology and people get used to that terminology, it might be easier for them to talk about it. Instead of poop, you say stool.
Yeah.
It might be a little bit easier to talk about stool than poop because especially kids, they start giggling as soon as you start talking about feces or poop or whatever, right?
Yeah.
So yeah.
Okay, thank you.
Thank you guys.
Bye-bye.
Thank you all so much for joining us today. It was lovely to have you all here. Great conversation, as Rachel mentioned earlier, to have over the lunch hour. We must all be in healthcare. And we look forward to seeing you for the next one.
Yeah.
Thanks everybody for coming.
Thank you.
Thank you.
Okay.